Sharpen, Masters of Surgical Education.
Hi, I'm Samuel George. I'm a consultant plastic surgeon and I specialize in hand and peripheral nerve surgery. And I'll talk to you today about how to examine the ulnar nerve. Now with the ulnar nerve examination, you want to start with inspection. So when inspecting for ulnar nerve, you want to inspect for the hypothenar bulk, or the muscle bulk in the hypothenar eminence, to see if there's any wasting there. You're going to also inspect the back of the hand for guttering between the metacarpals, as the interossi might be wasted. The other thing you might notice when you're inspecting someone with a more severe ulnar nerve problem is clawing. Now clawing is hyperextension at the index and the little finger. So it often looks like this. It is not like this. It is not flexion of these joints. It is like this. Now this is more the hand of benediction, as they say, and this is from actually an anterior interosseous nerve palsy and its inability to flex these fingers. Well, these are being flexed. This is not ulnar claw. Ulnar claw is this. So it's hyperextension at the MCP joint. Nothing to do with flexion of these fingers. Okay? So that's what you might see. So the other observation you might have is this. This is called Wartenberg sign. Now Wartenberg sign is the abducted position of the little finger. Now this has nothing to do with your abductor digiti minimi, because this is not working in an ulnar nerve palsy. But what does happen is, because your intrinsics aren't working, your third palmar interossi is responsible for adducting the finger. So because that's not working, or it's weak, the finger sits in an abducted position because the extensor digiti minimi has an ulnar pull to it. Normally, the tone of the third palmar interossi will keep the little finger in this position, but when that's not working, the pull of the extensor digiti minimi overcomes this weakness and makes your little finger sit in this position. And that is Wartenberg sign, and it's another sign of ulnar nerve palsy. Now you start your examination after inspection with sensation. So you test for sensation at the little finger and the ulnar half of the ring finger, and you compare it to the other side, and you can use 10-10. So say, what is this out of 10? And then ask them what this is out of 10, and you have a ratio between the two. Ensure that they don't have any symptoms on this side. If there is, find another spot to test the sensation on. If you follow the nerve back, you will come to a point where the nerve gives off the branches to the two lumbricals, which is coming from the common digital nerve. You can't really test the lumbricals in isolation, but if you go further back, you will have the branching off of the deep motor branch of the ulnar nerve. So the way to test the deep motor branch of the ulnar nerve is to test the intrinsics. Now there are various ways to do this. One way is to ask the patient to spread their fingers, and you try to close the fingers in against resistance. The other way you can do this, ask the patient to cross these two fingers. Say, can you cross your fingers? And they can't do this if they've got intrinsics which aren't working. There's also the Petres test 2 sign. Ask the patient to move their middle finger back and forth. So you're abducting your middle finger, and you can't do this without working intrinsics. The other thing is the froments. So the froments is basically using a piece of paper and putting it between the thumb and the index finger like that. And then what you do is you ask the patient to stop you from pulling the paper away like that. Now, if they've got working adductor pollicis, which is a very strong adductor, what they'll do is they'll use the adductor to stop you from pulling the paper out. If that's not working, what they'll do is they'll cheat and use the FPL muscle, which is supplied by the median nerve. So when you try to pull the paper out, they will do this to try and stop them, because the adductor is not strong enough. So they do this, and that's a positive froment sign. And the other thing during inspection you want to look for is the bulk of the first dorsal interossi muscle there, and that is the last muscle supplied by the ulnar nerve. To ask the patient to bring their thumb towards their index finger like this, and just feel for the bulk here. Basically, it would become hollow if there's an ulnar nerve palsy. Once you've tested the intrinsics, you go down, then you come to the Guyon's canal. Here you want to test for any compression by doing a Tinels at the Guyons. And you want to do quite a firm hammer action here. There's a soft bit here where the antebrachial fascia is and the volar carpal ligament, and that's where you want to examine for your Tinels. You can also test here, but slightly less reliable. If you go further back, about 8 to 10 centimeters proximal to the wrist crease, and a lot more proximal than people think, is where your dorsal cutaneous ulnar nerve comes out, and that goes and supplies feeling here. So what you want to do next is test for sensation on the ulnar leading edge of the hand. What this tells you is that there is compression of the ulnar nerve or an injury to the ulnar nerve more proximal than the Guyon's canal, because this branch goes outside Guyon's canal. Now, once we've finished examining the ulnar nerve of the hand, we need to move up to the forearm. So the ulnar nerve supplies the FDP muscles to the ring and the little finger, so that flexes the distal interphalangeal joint, and also the FCU muscle. Okay, so you can examine both those tendons and the FCU muscle by just reciprocating those motions. Then you go further back to the cubital tunnel and you want to examine the nerve as it goes through the cubital tunnel. This is between the olecranon, which is the pointy bit in your elbow, and the medial epicondyle, which is this other bony prominence there. Between these 2 points travels the ulnar nerve. Okay, so it goes through the FCU fascia, underneath the Osborn's ligament and fascia in the cubital tunnel, and then up the arcata struthers, which is the medial intermuscular septum going and joining the triceps muscles. So what you want to do here is you want to feel for the nerve and see if the nerve is very irritated there, and you can just roll the nerve there between the 2 bony prominences as well. Then do a Tinels, so just tap firmly over the cubital tunnel and see if they get electric shocks going up their finger, the little finger and the ring finger usually, just electric shocks, and just keep tapping there. And then the next thing you want to do is also try and see if there's a Tinels further up on the FCU fascia and up where the arcata struthers is. Now this is more relevant when someone's already had a cubital tunnel release or an anterior transposition and they've got recurrent symptoms. Sometimes moving the nerve forward or anteriorly creates 2 further points of compression at the FCU fascia and the arcata struthers. So you want to see if there's any Tinels there that's causing irritation to the nerve. After you've done this, what you want to do is make sure that the nerve is not actually subluxing. So put your finger on the medial epicondyle, that bony prominence, and then get the patient to flex. So when they flex the elbow, if the nerve is subluxing, it will flip across your finger, which is sitting on the medial epicondyle. So it flips across, and then you can feel it flip across, and you know that it's subluxing, and something else might need to be done, like a medial epicondylectomy, where we shave the bone down, or an anterior transposition, where you move the nerve anterior and secure it there so it stops flipping across that medial epicondyle, causing further irritation and inflammation to the nerve. After you've completed your examination of the ulnar nerve in this area, you want to rule out any proximal compression. So the more proximal areas that can be compressed here, the ulnar nerve, think about it, comes from the C8 and T1 nerve roots as it comes out of the spine and then forms the medial cord. Now, a very common place for this nerve to get compressed is at the thoracic outlet. Now, this can be at the pec minor, at the subclavicular space, or at the actual thoracic outlet where the 2 anterior and middle scalenes muscles basically cause compression. And between that and the first rib, so that triangle where the nerves come up from, can cause compression. A lot of the anomalous or extra anatomical structures that you can get bands between these scalenes muscles. They often cause compression on the lower roots of the plexus as well. So it can overlap and actually mask the cubital tunnel syndrome. So people often have cubital tunnel symptoms, but might have a thoracic outlet syndrome rather than a cubital tunnel syndrome. Sorry. So what you want to do is see if there's a Tinels at Erb's point, which is where the nerves leave between the 2 scalene muscles. You can do a Tinels there. You can also do all the thoracic outlet tests like Roux tests and Adson's tests and things like that. Or just mention it after you finish your examination. If you're doing an exam, after you finish your examination, so I would look for any further signs of proximal compression of the ulnar nerve, such as at the thoracic outlet, at the spine, things like that. And you know that you've completed your whole examination then.
Sharpen, Masters of Surgical Education.